Sure. Yes. I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Please have a seat. Yes, Mr. Moss.
Thanks, sir. Dr. Molyneux, you just start by giving us your full name, if you would, please.
Certainly, it's Anthony John Molyneux.
Thank you. And if we could have on screen, please, AHCH 30253. We see, do we not, a copy of your statement to this inquiry. It's dated the 30th of July 2025, so this year. Can you just confirm that the contents of that statement are true to the best of your knowledge and belief?
That's correct, yes.
You tell us on that first page of your statement that you're employed as a consultant child and adolescent psychiatrist by Alder Children's NHS Foundation Trust, is that right?
That's correct indeed, yes.
Since, I think, 2019?
Yes, April 2019, yes.
You qualified as a doctor, I think, first in 2009.
Yep.
Your route to that, I think, was that you did biological sciences at Cambridge and then came here to Liverpool University to do a medicine degree.
That's correct.
Thank you. You've been a member of the Royal College of Psychiatrists since April 2014 and a consultant since 2017.
Correct, yes.
Thank you. In paragraph 2, you explained that you carry the neurodevelopmental lead role for Alder Hey Psychiatry Consultants Group, and that you've done that since July 2019. Is that right?
Correct, yes.
At the time of your involvement with AR, did that include any oversight of the autism spectrum disorders and ADHD services?
I wouldn't say so much as oversight. The neurodevelopmental lead role is not an executive role as such. Each member of the psychiatry group at Alder Hey, the consultant group, has a different nominated lead role. They're not executive roles, they're not paid, or they're not separate jobs, so to speak. So one of my colleagues will have a specific remit for research, one will have a specific remit for Mental Health Act, pharmacology, and so on. And mine is the neurodevelopmental lead role. So really what it entails is being the main link between the neurodevelopmental pathways. It's recently become integrated into one pathway actually, but the main link between that pathway, those pathways, and the psychiatry group.
Thank you. We're going to hear evidence, particularly tomorrow, that in the way things were initially organised, it was the paediatrics team, I think, that led on the diagnosis. Is that right?
That's carry on, sorry.
Of autism.
That's my understanding of it, if I can get the timings right. So the new autism pathway, which was centrally coordinated for the first time, really, outside of the remit of the governance of community paediatrics, that new way of doing things began around 2019-2020, as I recall.
Thank you. We'll pick that up with others. But in broadest overview, is this right that you took over from your colleague Dr. Ram, from whom we'll be hearing next, in July 2022?
For the care of AR?
The care of AR.
Psychiatric care, that's correct, yes.
And you were the assigned consultant psychiatrist on the team for AR, and you remained assigned in that way to AR until you discharged him in, I think, April of 2024.
Correct, yes.
Thank you. I want to turn against that introduction to ask you about the time when you were allocated AR's case and your awareness of the background and risk information in relation to him. And I'm actually going to take a little bit of time with this because of its potential importance. So when you first were allocated AR onto your caseload, did you receive a handover?
I did indeed, yes.
Who was it from?
It was from my colleague, Dr. Ramasubramanian, Dr. Ram, we call it.
Just keep your voice up, a little louder.
Sorry, Dr. Ramasubramanian, yes.
Yeah. And how was that handover completed? Was it in person? Was it electronic? How was it done?
It was an in-person handover.
How long would the handover have taken?
Oh, I mean, I don't think any more than half an hour or so.
Thank you. And in terms of your sources of information, if we just have on the screen briefly, for the moment, AHCH 30162. AHCH 30162. You're our first witness from the CAMS team, and this, I think, is the electronic patient system, yes?
Yes.
You'd have had access to that, presumably.
In theory, access, yes.
Well, what do you mean in theory access?
Well,
Did you have access?
yes, I'd have had access to it. Correct. Yeah.
And as part of getting to know the backstory, to use a lay term, of your patients like AR, would you use the electronic patient system records to look back and understand the history?
I would always do so to get a decent corroborative background picture of what was going on with any patient I was handed over from another consultant.
What was the expectation as to how detailed that review should be?
So the handover I had focused on the live primary issues at the time, really. So as I recall, and I think this, well, I'm sure it's there in my Rule 9 statement, the live issues at the time were, the main foregrounded issue.
I'm going to interrupt you, Dr. Molyneux, because if you can listen to my question,
Sure.
focus on the question that I'm asking,
Of course.
and seek to answer it.
Of course.
So my question was what the expectation was in how detailed your review of the records should be.
Well, I would say that the expectation was that I would conduct a reasonable review of the records.
Not the whole of the records.
Well, it would be impossible to conduct a review of the whole of the records.
Can we have on screen, please, AHCH 30309? Do you see that this is the standard operating procedure for the Sefton CAMS? Do you see that there?
I do indeed, yes.
If we go to page 16, if we see in the middle of the page, the paragraph, as part of risk management, case management,
Yeah.
do we see there that it includes this? It is important that clinicians review, and then these words, the whole EPR record at each appointment to ensure that they're aware of any risk factors or contextual risk that might have arisen since the last appointment.
I see that, yes.
Is that not the standard operating procedure and the expectation?
That would appear to be the case, yeah.
And your practice, therefore, in not reviewing it in totality, I think you indicated that it wouldn't be practicable to do so. Does that suggest that there's a mismatch between what the expectation was and what the practice was, or certainly your practice was?
I wouldn't say so. I mean, when it says it's important that clinicians review the whole EPR record, I mean, it's important, and it's important that it's reviewed. I would say that I did carry out a reasonable review.
Apart from the electronic patient record, did you have, and what was said to you verbally in the handover, did you have any other sources of information?
I can't think of what other sources of information would look like other than verbal handover and written records.
So far as other agencies were concerned, again, it may seem an obvious question to you, but please just help us.
No, of course.
Would you have access to local authority records, for example, or would you be dependent upon how liaison with the local authority had been written up in the electronic medical records?
So it would be a bit of a mixture. So there's a section on the EPR where scanned documentation from other agencies working with us would go in. That works a lot better now than it has done in the past. I think it's fair to say. Also, it would be those sorts of allusions to and the kind of core elements of important interagency discussions would appear in things like session notes. Another good kind of go-to source. I mean, obviously, I'm aware that you're not familiar with the details of the record yourself, but another good and robust.
Taking it shortly,
Yeah,
I think from what the answer you've given,
yeah,
you would only see matters from a local authority to the extent that they've been scanned into the electronic record or contained within session notes within the electronic record. You didn't have direct access to other agencies' record keeping.
No. That's forgive me. I don't know whether that's changed very recently. I know that there are discussions around a kind of
Just deal with how it was at the time.
Not to my knowledge, I wouldn't have direct access to local authority information or anything like that.
And what about non-mental health medical records? Did you have access to medical records outside the mental health records? Physical healthcare records,
yes.
GP records?
Well, there's a couple of things to say about that. I'm fortunate to work for Alder Hey NHS Foundation Trust, which obviously has, a physical health component as well as a mental health component, so to speak. So it's relatively easy because it's the same NHS trust. It's very easy to kind of access physical health, secondary care and tertiary care physical health records. GP information, as I understand it, can be obtained and could at the time by something called the National Spine. But my understanding of the practice was that certainly at the time, again, this is my understanding of the practice, that would be something that would need to be requested through admin staff.
So I'm going to go through some aspects of the history of AR from before July 2022. And I want you to just help the inquiry as whether you were aware of it.
Okay.
So were you aware when you took on AR onto your caseload that he had admitted taking knives into school on some 10 occasions leading up to an incident where Childline were called in October 2019?
No, I was aware of. Will you allow me to read out from the initial psychiatric letter that?
No, but if we have on screen AHCH 30163.
I mean, the short answer is I wasn't aware of it.
Just pause. Let me bring it up on the screen.
Of course.
AHCH 30163 at page 95. Do you see at the bottom there an entry in the electronic records for the 15th of September 21? Do you see that there?
I do indeed, yes.
And if we go over the page, do we see that that's by Dr. Oseri? About 6 lines down, clinicians present.
6 lines down. Yes, I can see.
Yep. And then under presenting complaints, we see 1 and 2, and then there's a history that's given.
Yes.
Is that what you were seeking to read out?
That looks like what's in this letter that I've got here, yeah.
That's why I'm taking it. So rather than reading it out, we can obviously see it on screen.
I understand.
So we see there, AR tells me that he started experiencing worries about leaving his house in September 2019. This was related to AR being bullied at his old school, Range High School, which is a mainstream school. Due to this, he was noted to attend school carrying a knife in his bag, which led to his permanent exclusion from the school. There was no history of AR being physically aggressive towards anyone at school on this occasion. So was that the sum total of your knowledge in relation to that?
Yes.
And so you didn't know that that had been on 10 occasions that he carried a knife into school?
Certainly did not know that, no.
You didn't know that although his explanations for that perhaps varied, that there were some indications that he was bringing the knife in with a distinct intention of causing at least very serious harm.
I absolutely did not know that, no.
So that was October 2019. And then in an ICT lesson on the 15th of November, did you know that AR had been engaged in searching for material on a school computer relating to school shootings in America?
No.
Did you know that AR had been involved in searching for a number of graphic images of degloving injuries on the school computer at about the same time?
Not at the time, no.
When did you first learn about that?
Since the tragic events of the 29th of July 2024.
Were you aware that on the 29th of November 2019, during a lesson in relation to talking about setting up a new business, that AR had said that people would think he would kill them as they did not know him? He went on to say, people don't trust others they don't know in case they get murdered. Were you aware of that statement of concern?
No idea at the time, no.
On the 3rd of December 2019, during an art lesson, culling in images from the video game Call of Duty, AR questioned why he was allowed to look at those images from Call of Duty but couldn't look at guns on the internet, and then asked to look at a picture of a severed head.
Again, these are things I've only found out since July 2024.
And were you aware that AR had attacked a student with a hockey stick in an incident in December 2019?
No.
You weren't aware of that incident at all in addition to the October one?
No.
The statements that he gave in relation to that were perhaps contradictory at times, but again, there was an indication that his intent, at least on some accounts, was that he would have been prepared to use the knife and potentially to kill the person he was targeting.
I didn't have any knowledge of that at the time.
And were you aware that what he ended up doing on that occasion, when he couldn't get hold of the person that he perceived to be the bully, was that he just attacked another boy, seemingly at random, who happened to be in the corridor?
Again, these are only elements that I've discovered since July 2024.
Were you aware that on the 1st of February, on the 29th of February 2020, that in relation to that incident, he was convicted and received a 10-month referral order?
No.
Were you aware that in the strategy meeting in December 2019, it also emerged from the school that he had been looking up matters or discussing matters in relation to the Manchester Arena attack and had said that it had been a quote-unquote good battle?
I had no idea of that at all at the time. And when I, if I might add, when I found out that since 29th of July 2024, I found that particularly chilling, actually.
And then 20th of April 2021, School Computer, still before your time as his consultant, but School Computer viewing web pages relating to the London Bridge terror attack and then speaking in some detail about the IRA, MI5 wanting to kill people in the IRA and showing a distinct interest in those sort of topics?
No idea at all.
5th of November 2021, AR trashing the house, leading to his mother calling the police.
Nope.
The 30th of November, AR kicking his father, throwing a plate at a rental car, causing damage to the car windscreen.
No.
Then the 21st of January 2022, where AR had made comments in school about the Holocaust, talked about the death of Diana, water poisonings, and saying that sometimes violence was necessary.
Nope.
The 17th of March 2022, moving closer in time to when you took over as the consultant psychiatrist. He went missing from his home address. He was found on a bus later the same day in possession of a knife. Were you aware of that?
Nope.
And were you aware that when the police asked him about it, he made remarks about wanting to stab people, and either saying that he had thoughts about making poison or that he had tried to make poison.
No idea.
And then a further incident on the 14th of May, when calls were made to the police after AR had thrown food and overfilled the bath, so to flood it. Were you aware of that?
No.
Would you not have expected, in light of the candid answers that you've given, that you weren't aware of those, say for some knowledge around the October incident? Would you have expected to have known about those matters? Were they not important?
Of course, yes. I think it's crucial that somebody in my position ought to know those things.
Keep your voice up, please.
I think it's crucial that somebody in my position ought to know those things at that time.
Thank you. And we'll come back to this, but any assessment of the risk that AR posed to others while you were the treating psychiatrist would be deeply flawed without knowledge of those matters.
It would, let's just say it would have a significant blind spot.
Would you not agree that it would be likely to be deeply flawed?
I think that's arguable, yeah.
So, Dr. Molyneux, not all of that history in the detail that I've explained it was available in the medical records.
No.
But aspects of it were. Were you aware that the hockey stick incident was in the electronic records, that there was a reference to it?
No.
Have you looked at the records in preparation for your evidence and seen that?
I've seen it referenced in the bundle of documents that we have. I'm not so sure whether it's part of the overall chronology or part of our EPR that I've seen.
And the fact that AR had been subject to a 10-month referral order, again, I just give the paragraph references to the internal review. So 168 in the internal review by Alder Hay for the hockey stick incident, 177 for the 10-month referral order, is where it sets out that that was information that was available from the records.
I didn't know that.
And the fact that he'd taken a knife into school with the intention of using it, again, was recorded in the records. Sir, for your note, AHCH 30162, page 3.
Thank you.
So we don't necessarily need to have it up on screen, but it's there in the electronic records.
Again, that seems to be at variance from what's in the clinic letter that I saw. Yeah.
But that's the importance of reading through the notes and being fully informed of them.
It is, although, you know, in my defence, if I see a good psychiatric letter that tells me something, that's, you know, that's. I think that's it's reasonable to conclude that that's accurate. And of course, if I might say a little more on that, when any doctor or clinician meets a patient family for the first time, it's always not just an opportunity but an obligation to get a complete history, an up-to-date history from the new patient, the new family. And that was an opportunity that I had on the first home visit of the 28th of July 2022. And I would say that crucially, and what strikes me as different from pretty much every other case I've ever come across within my professional career, whereas I would have expected that information to be foregrounded in what the family told me when I spent an hour and a half to 2 hours with them on that date in July 2022, I didn't hear any of that.
No, and in due course, we will ask questions, of course, of AR's family. But in a sense, is what you're telling us that you relied on the last clinic letter and didn't yourself go back through the records and see all these references that were there to be seen?
I guess It's a question. It seems to me it's a question of unknown unknowns, isn't it? If you get good assurance from a good assessment letter that the state of affairs is a certain state of affairs, and you get a good handover, and you look at a selection of recent letters and recent notes and so on, one would expect that that gives reasonable assurance. It would be impossible to spend the requisite amount of time going through every aspect of any patient's clinical record.
Well, that's what the standard operating procedure appears to envisage. But let me just continue, because the fact that AR had been viewing inappropriate content online in relation to terrorism was also in the notes. Are you aware of that now?
I'm aware of that now, yeah.
The fact that he'd researched, that's AHCH 162, page 9, sir, for your note.
Thank you.
The fact that he'd researched the Manchester bombing, there's a reference to that in the CAMS notes, 30162, page 10. Are you now aware of that?
Say again, the Manchester
The
bombing.
Manchester bombing reference was particularly chilling, and you weren't aware of it.
Yeah.
But it was in the electronic CAMS notes.
Correct, I wasn't aware of it at the time, no.
The London bombings reference as well, 163, page 19. The incident of throwing juice over his father and assaulting him, same document, page 29. Trashing the home, same document, page 119. And the going missing from home, AHCH 30164, page 37. Doctor, all of those were within the records.
Indeed.
So you've referred back, can we go back on screen to AHCH 30163 at page 95, please? You've referred to, I think these are the internal notes, I think you're referring to a clinic letter that may have gone out, but with the same content, presumably. So AHCH 30163, 95. And if we just go on to 96 so we can see the substance of it again.
Yeah.
What grade was Dr. Asari?
Sorry?
What grade was Dr. Asari at the time?
She was a registrar.
Yeah. So more junior to you.
Correct.
And did you not think that it was incumbent upon you to do a proper check through the records rather than just relying on this one clinic letter to see what the detailed information was since AR had come to CAMS?
I mean, I know Dr. Asari. I worked with her at the time. I regarded her and continue to regard her as a good, competent doctor. A registrar is not by any means a junior grade. Somebody at a registrar level has been working as a doctor for a number of years, a qualified doctor for a number of years. I never had any issue with her assessment capabilities at all, and neither did anyone else. She was a very popular and very valued member of the team. My sense of what this likely speaks of, and this is something that I think, this is my impression now, that I think has become more visible in retrospect, of course, in hindsight, is there would appear to be repeated instances throughout AR's trajectory, through our service, and evidently other public sector agencies too. There would appear to be repeated occurrences of the family appearing to, shall we say, stage manage the presentation of information provided to professionals.
Dr. Molly, you spoke earlier about unknowns.
Yes.
The fact that parents of a youth might downplay and not volunteer information about their involvement in violence is a known. That's a risk that you as a psychiatrist should have been taking into account. Would you not agree?
How can I answer that? I guess it's a possibility.
Well, is it a possibility, or is it a simple fact of competent psychiatric practice? If you're dealing with offenders who are youths, it's something that you should be prepared for all the time, that the parents may downplay that or may not wish to volunteer information about it. That's just a risk that you should always have in mind, is it not?
It is something that you should always have in mind. But again, I think you can only take reasonable steps to try and mitigate that. Again, it falls back on unknown unknowns, I think. And my sense of working with this family, and again, this is something that's only possible to see with the benefit of hindsight, and other of my colleagues have had the same on reflection and with the benefit of hindsight. Others of my colleagues have had the same and reported the same experience. The level of studied manipulation of presentation is something at a level, and again, it's only possible to see this, I think, with the benefit of hindsight, but it's something that's there at a level that I've never experienced before.
Dr. Molly, I'm going to come back to that.
Of course.
But can I please, without discourtesy, ask you please to focus on your standards of practice,
Yes.
and the standards of CAMS,
Yes.
rather than going to the sidelines and looking at the family and what they may or may not have volunteered. Because what I'm asking you about here is matters that were available and were on the records. And what I'm going to suggest to you that the picture that emerges is twofold. Firstly, the system within CAMS for keeping track of the risk information was very poor, because as the consultant taking over, there should have been a system whereby this important historical information was visible to you. Do you agree with that?
I agree that, yes, public sector systems in general...
Not public sector systems, the CAMS system at Alderhay. Please focus on the questions that I'm asking you.
I would say it should have been better, and steps have since been taken to improve it.
And the second aspect, Dr. Molyneux, is that you failed in your duty adequately to check the notes yourself, to inform yourselves of this, of this important risk information that was visible on the notes had you checked them more thoroughly.
I don't accept that submission that I failed in my duty. I believe that I took reasonable steps to glean a reasonable level of assurance from the notes, from the verbal handover that I had, and then my initial meeting with the family on the first home visit of the 28th of July 2022. I feel that all else being equal is a reasonable level of triangulation of information.
But I've been through, again, without going to the issues about the family, I've been through what was visible from the notes, which is many, although not all, of the longer list that I went through with you at the start. So how can it be, if you met your professional duties in that regard, that that information was visible on the records, but you were ignorant of it?
Because it's not easily visible in the records, I guess. It's so it remains in the territory of unknown unknowns. If you don't know something's there, you can't go. You can't go looking for it. If you don't have a suspicion that is there, you won't have an indication to go looking for it.
Well, that brings into play a third issue then, doesn't it? That the handover from Dr. Ram can't have been all that effective, because this whole aspect of these histories of his earlier offending and risk information, you say unknown unknowns, but if there'd been a good handover to you, you would have been put on notice. There was quite a lot of concerning risk information in 2019 and 2020 in particular, and then a worrying incident in March 22 where he's been found with a knife.
I guess I can't speak for Dr. Ram. However, knowing now some of the all of the more granular detail of those earlier aspects of of AR's journey through our service, I think we need to be careful about judging what may or may not have been known by clinicians who were involved at the time. I think we need to be careful about judging that and viewing that with the benefit of hindsight. For example, without the benefit of hindsight, without the benefit of, without the experience of the unprecedented experience of the tragic events of the 29th of July 2024, without that knowledge, for example, 3 prevent referrals that each say, nothing to see here, nothing to see here, nothing to see here, I would say gives a good level of assurance that there is nothing to see here.
The repeated incidents of carrying knives into school and then being found with a knife in March 22, just months before you took on, that's just central information that you had to know, leaving aside the conclusions from the prevent referral. That's not hindsight, and it's not unknowns unknowns. They're matters on the record that you as the treating psychiatrist were not aware of,
no.
And I'm going to suggest did not inform yourself of from the records.
Again, Mr. Moss, I can't inform myself of them if I don't know or have any indication to suspect that they're there.
If you had been aware of the full background as I've outlined it to you, would have that affected your assessment of AR throughout the time that you were his psychiatrist?
It would certainly have altered the perspective, yes. I'm not saying necessarily in a fundamental way, but it would have altered the perspective, yes.
And would this be right, that most fundamentally, the way in which it would have altered the perspective was to put a focus upon AR's risk to others?
It would have shone more light in that direction, I agree, yes.
Because I think you're aware in general terms that by the time that AR was being discharged from CAMS altogether, and that was slightly after he'd been discharged from your psychiatric care,
Yeah.
the risk to others was said to be, quote unquote, none on the 23rd of July, 2024.
I don't think that was an entry by myself.
No, I didn't suggest it was. But that would not have been the assessment of his risk to others, given that significant forensic history, would it?
I can't really make a definite statement on that because, again, what you've got in the intervening time is the perspective that's emerging from reviews of AR directly, during which time he's saying repeatedly to people that or denying that he has thoughts of harm to others, and parents aren't foregrounding any risk in that direction either.
Potentially, would all of that information about AR also have been relevant when you consider the question of diagnosis and whether he was suffering from a mental disorder, and if so, which?
Could you repeat the question, sorry?
Yeah. Potentially, would all of that information about AR also have been relevant when you were considering the question of diagnosis and whether AR was suffering from a mental disorder, and if so, which disorder? It would have been relevant information to take into account.
It would have been relevant information, even if just to provide some context.
What was your actual understanding of the risk that AR posed to others when you took over his psychiatric care?
Minimal.
Do you now accept that when you say minimal, do you mean your understanding was minimal or you thought the risk was minimal?
I thought the risk of harm to others at the time I took over his care was minimal.
And would you now accept that that was inadequate?
Well, early on in my involvement, I obviously got a sense from parents and he himself. He denied thoughts of harm to others, and parents were, denying that there was any issues, or not bringing forward any issues in that area.
But again, forgive me for going back to it, but if in March he'd carried a knife on a bus and had told police officers he had thoughts of stabbing people with it, an assessment that his risk to others was minimal, leaving aside who was responsible for that, but objectively speaking, that was not an adequate assessment of his risk to others.
Objectively speaking, it would appear to be the case that, as you intimate there, in March 2022, his risk of harm to others was not minimal, no.
Were you aware that there had been a referral to forensic cams?
When I took over the case?
Yes.
No.
Did you become aware of that while he was on your caseload?
No.
Is that something which you think you should have been aware of if the systems had been working properly?
The system in the wider sense, yes.
Could we have on screen, please, GMMH 507? And just so you get your bearings on this, can you see that this is a letter dated the 9th of March 2020?
Yes.
If we just go over, please, to page 2. It's from Mr. Hicklin, John Hicklin.
Yes.
And he says there, if we could just have the text of the that's visible in large, please, Sarah. He was saying, I made comment that risk assessment will be complicated by his likely diagnosis of autism spectrum conditions. The known evidence in this field concurs with the discussion we had about AR with professionals. And then he outlined some particular risk factors, including specialist interests associated with the condition, hostility to parents, lack of awareness of wrongdoing, deficits in empathy or lack of recognition of fear in others, not seeing consequences. And he goes on to say, I'm of the opinion that assessment by our service, that is to say FCAMS, is not indicated, as until his diagnosis is complete, we would not be able to contribute further to the understanding of risk. He's talking about the meeting that he'd attended. I made comment, although AR being outside of access to full-time education increases the risk, we would therefore support access to appropriate provision being expedited. He would also likely benefit from access to social support outside of the family. Reported that the case will step down to early help and suggested this letter can be shared with relevant professionals. This case will now be closed to FCAMS, but any professional can contact the service for clarification of this letter, or if a view is indicated because of a significant change in circumstances or risk behaviour. So I don't think you would have been aware of that advice from FCAMS at any stage when you were treating AR.
Say the last bit again there, sorry.
I don't think you would have been aware of that advice from FCAMS at any stage when you were treating AR.
No, indeed.
And it follows that to the extent that this was saying, we can't help more on the complex question of risk until the autism diagnosis is made, but you can come back to us if there's a relevant change. If that's what this letter means, were you aware that in February 21, AR had received his autism diagnosis?
I was aware that, so when I took over his case, I was aware that he had an autism diagnosis. I couldn't, looking back, I don't think I could have pinpointed it to when he got it, but I was aware that he had an autism diagnosis.
But it follows, I think, that you wouldn't have been aware that there was potentially an invitation for FCAMS to refer him back to FCAMS for further assessment of risk once the diagnosis was known.
I wouldn't have been aware of that. By the way, I'm not entirely in agreement with the conjecture that an autism diagnosis needs to be made before risk can be taken into account. I don't necessarily agree with that opinion, but that's their opinion at the time.
We're going to hear evidence that these letters were not, in fact, scanned onto the system. So in fairness to you, it looks as though these letters wouldn't have been available if you did go back through the notes. Were you aware of that it's now known that there were scanning problems? I'm
aware now that it's now known there were scanning problems. I think it's worth saying and worth flagging that I think this was around about February 2020 sort of time, wasn't it? March 2020?
This is 9th of March.
9th of March 2020. And I don't think, not just for our organisation, but throughout the public sector, I don't think the huge impact of the COVID-19 pandemic and all of the tumult that brought in right across the public sector, I don't think that can be overstated.
Yeah, we'll pick that up with Dr. Killen in terms of how this came about. So you didn't know about FCAMs. You did have some information about PREVENT. I think you say in your statement that there were 2 occasions when that was mentioned.
Yes, indeed. Yeah.
And you mentioned earlier in your evidence this morning that what you took from that, I think you used the phrase "nothing to see here." Is that right?
Is that the phrase I've used in the Rule 9 statement?
I'm paraphrasing, but I think that's the phrase you used earlier this morning.
Okay, beg your pardon. But you're correct in substance. My recollection is that there were only I only encountered 2 references to PREVENT throughout my entire period as AR's consultant psychiatrist. One was a reference and a passing nothing to see here reference or equivalent really in the multi-professional meeting of I think the 25th of May 2023. Another reference was in a final informal review of the case as we approached discharge, as I had an informal conversation with the case manager at the time, Catherine Morris.
Did that not, even if they appeared to be reassuring references, did that not stimulate some sort of professional curiosity on your part to go back through the notes and see why there'd been a PREVENT referral and to understand how that reflected on the earlier notes before you became involved?
Well, the first thing to say about that is that only one was mentioned, and I did recall in that final conversation with Kate Morris, I did recall my recollection of what the substance of the PREVENT discussion was about at the 25th of May 2023 multi-professional meeting, and it was my recollection was that there was some relatively there's a relatively trivial reference to Hitler or something like that. I think it's a misremembering of the Gaddafi PREVENT referral, which I think was the second referral. Well, that's something I've only been able to kind of clarify since.
And so if, and again, I have to summarise quite a lot of evidence, and I'll try to do so in a way that's short but I hope fair. If, for example, the first PREVENT referral can be summarised in this way, that there was a mixture of really quite concerning information about AR that was put through on that PREVENT referral, but the assessment was that he was not somebody who was prone to be radicalised into terrorism itself, but this was more likely to arise because of his autism, and that CAMS, together with other agencies, but particularly CAMS, were giving the requisite help in relation to those risks. That would have been important for you to know, wouldn't it, that that was the overall assessment of where PREVENT were coming from?
It would.
Rather than it's a trivial referral, there's nothing to see here.
I think the again, my sense of the kind of, it's an important negative aspect. So my sense of what the one referral was the second one, which I think was the Facebook post, which I think was about Gaddafi, wasn't it? But my recollection was at the time it was to do with Hitler. But the first one, Yeah, it would have been important for me to know the details of that, yeah.
But again, you didn't go back through the notes to look at what was in the CAMS notes about that, including in relation to the first referral.
Well, again, my understanding was that there'd been one prevent referral that had been about something that professionals regarded or evidently regarded as, relatively trivial and no further action actioned by the prevent process. And that was the sum total of my knowledge. If the sum total of my knowledge is that there was one prevent referral, I don't have an indication to go and look for others.
Thank you. I'm going to move to a different topic now, which is the ongoing work that you were involved in with AR from when you took him on your caseload in July 2022 through to September 2023.
Yeah.
So I think if we look at paragraph 11, let's just have it up on screen, paragraph 11, page 4 of your statement.
I don't see it, sorry.
It's just coming.
Okay, sorry, apologies. Paragraph 11, yeah?
So paragraph 11, page 4, you deal there with the fact you first saw, I think, AR in person on the 28th of July, yes, 2022?
I didn't see him in person on that home visit. He'd gone up to his bedroom before my arrival. That was an hour and a half to 2 hour conversation with
Thanks.
Alphonse and Letitia in the downstairs living room.
I was taking it too, sorry. So you had your first home visit on the 28th of July, but he himself was present, but not talking to you. He was in his room.
He'd absented himself prior to my arrival, yeah.
You set out there as this writing, and try to take it relatively shortly, that the principal concern at this first meeting with his parents, with you, was his weight loss due to restrictive eating and long-standing refusal to leave the house. Was that the main concern at that stage?
Correct.
You agreed, I think, to prescribe him a one-off dose of diazepam, a mild sedative, to enable him to be able to attend an in-person appointment at the Southport clinic.
Correct.
And you explain in paragraph 19, if we can go on to page 7, please, Sarah, that AR and his father then attended that clinic as planned on I think the 1st of August 2022. Is that right?
That's right, yes.
What was your impression of him on that clinic appointment?
Well, as I say there, I think, or in subsequent paragraphs, he came across as somebody who wasn't interested himself in being there, didn't particularly want to engage, wasn't depressed, was euthymic in mood, I guess. He came across as a kind of, I regarded him as a average, sullen teenage boy, really.
You say in paragraph 20 that overall he presented as stable in terms of his mental health, yes?
Yeah, correct.
And you also say right at the bottom of the page that there's no evidence of any thoughts of harm to self or others. Would you have specifically asked him about, I'm going to focus on risk to others for reasons you'll understand, would you have specifically asked him about the thoughts of harm to others?
So my recollection is that I asked him about thoughts of harm to self in the appointment the second appointment of the 29th of December 2022, which I insisted on sort of seeing him alone. I did a comprehensive, tour of all of those, risk parameters.
Forgive me, but I specifically asked you about the risk of harm to others. So on the 1st of August, when you say there was no evidence of any thoughts of harm to self or others, would you have asked him about thoughts of harm to others?
I may have asked him. I can't say definitively that I did not.
And you'll forgive me for going back to it, but if you had known that as recently as March he'd been found with a knife, and this is not something that he said, the police have seen the knife, taken it off him and given it back to parents, and said that he had the knife because he wanted to stab somebody and had made reference to poison, those matters that you would have been bound to explore with him, however cautiously.
Of course.
But they weren't explored because you didn't know of them,
Correct.
in part because you hadn't read the records.
I hadn't had indication to pursue any further in the records from the reasonable assurance of ostensible clinical presentation that I was given from the documentation and the handover and the parental appointment that I had.
I mean, does it not concern you now that those matters were available in the records, that the most recent incident in particular, and that you hadn't picked it up? Does that not trouble you?
It does, yeah.
You explain in paragraph 21 that you discussed trying a different SSRI and to sertraline, and fluoxetine, I think, was the medication that you were thinking of. Is that right?
Fluoxetine.
Yeah.
That's correct, yes.
And you prescribed a low initial dose, I think, on this occasion.
Yeah, very low, yeah. Yeah.
I'm asked to explore with you whether you had thought about talking therapies may have been a better approach at this stage. Do you have any view on that?
I mean, you know, I can see why you're asking that question. So the way the CAMS, our CAMS service and CAMS services in general work is that so people will be assigned, you know, typically, and it works now. So people will be assigned a case manager who has a kind of primary therapist role. So they will meet the young person, provide that sort of basic talking therapy input. Then if there's a further indication identified for a specific talking therapy on top of that, that's a further referral that can be made. I mean, in this case, as with a lot of cases that I come across, it's important to, well, it's a primary importance really to establish that therapeutic relationship. And if you're in a position to be able to prescribe a medication for somebody that will take the edge off their distress, it's a big part of the therapeutic role of that is that it goes some way towards establishing a therapeutic relationship.
In terms of the recent medication history, take it from me for the moment, but I can bring it up on screen if you want me to. But as recently as the 7th of April of the same year, 2022, your predecessor, Dr. Ram, had indicated that she would increase sertraline up to 100 milligrams for 2 months, after which she said, without any clear improvement, it would be known that medication wasn't right for AR. So on one view, moving to a different medication might be thought to be contrary to what Dr. Ram's thinking had been, which was to try and increase dose of sertraline, but with a view that if that didn't bring about a marked improvement, that medication wasn't the way to go.
I think it's. I can understand why you're asking that question. I think this is within the remit, if you like, of acceptable variation between psychiatric practice. I tend to go to higher doses, probably less than the average of my colleagues, but there is variation amongst my colleagues.
You deal in paragraph 28 on page 10, the fact there was then a telephone review on the 1st of September, which I think was positive, is that right?
From memory, yes. Yes, I'd probably say it there, do I?
And in fairness to you, in terms of the new medication, Alfonso, AR's father, was reporting an improvement in presentation since starting on the fluoxetine. You had a further review, I think, on the 1st of December 2022, paragraph 29, just over the page, please. Mm-hmm. Is that right?
Trying to remember and sort of orientate myself a little bit now.
It's on screen if it helps.
Yeah, thank you. Yes, yeah.
So, from father, positive report in terms of weight continued to improve.
Yeah.
But on the other hand, as regards the fluoxetine, AR had stopped taking this some weeks previously. Is that right?
That's what I say there, yeah.
And again, we're taking it from the statement rather than going through lots of notes. And he said it was because he didn't feel it had any effect, yes?
Again, I'm having to go back. I can't remember, but yes, that's what I've written, yeah.
You said that you wondered whether you'd experienced the fluoxetine as somewhat over-activating.
Mm-hmm.
Then you say this, having momentarily overlooked the fact that he had, of course, been prescribed sertraline previously, you proposed that he might be interested in trying sertraline instead. Is that right?
Yes.
The reference to momentarily overlooking the previous prescription, I took you to the standard operating procedure in terms of informing yourself of what was in the notes. And of course, that was the medication that Dr. Ram had been attempting to use and had increased the dose of, which was in the very recent records. How did it come to be, Dr. Molyneux, if you were paying appropriate attention to the notes, that you thought about trying a medication that had already been attempted?
Well, you say it was in the very recent record. I think it was we're now April to December, aren't we? I think there's the gap, is it?
Yeah.
Yeah.
The treating records for that year,
Yeah.
and you'd had a handover from Dr. Ram.
Yes, in the July, yes. But we're now in the December.
But you'd just forgotten about that, had you?
Well, I mean, I'd momentarily overlooked it.
If it were suggested that that is indicative of a pattern, Dr. Molyneux, of you not paying sufficient attention to what is in past notes, what would you say?
Could you say that again, sorry?
Yeah, if it were suggested that that is indicative of a pattern of you not paying sufficient attention to what is in the past notes, what would you say?
I would say that's unfair, in my opinion.
Thank you. You go on to explain in paragraph 30 that having reviewed Dr. Ram's records since, you can see that she had previously prescribed sertraline. And you go on to say, in retrospect, in light of everything we now know, but couldn't have known at the time, and I've challenged you on that about what could have been known at the time, I wonder if this was an example of an attempt on AR's part to consciously and deliberately manipulate professionals. Just explain why you were making that reflection.
So this is a reflection that I've made in the process of doing the Rule 9 statement. I guess it would fit in with a general pattern, a general contextual pattern that seems to have been established by AR and his behaviour throughout his trajectory of involvement with all of the various services, but that wasn't apparent to me, certainly to me at the time.
And so just help us with what you're suggesting with reflection you think AR was actually doing. Why?
Well, I'm wondering if he was trying to manipulate professionals.
But if he had sertraline previously and he reported that it wasn't effective, hence trialling something else and going to fluoxetine, what would be the benefit for him of getting sertraline again?
Again, it's a wondering, without forming any definitive conclusions about it. It just the sense in retrospect through having worked with AR his approach to medications was that he almost seemed to have a kind of shopping list for exactly what he wanted in terms of medications.
Did you get the impression that he looked a lot of stuff up about medications, was knowledgeable about them?
I did get that impression, yes.
Was that unusual for someone of his age?
I don't think it's particularly common. I wouldn't say it was particularly uncommon. I mean, it might even be. Maybe I'm being too fair, even too unfair even to say that. I mean, you do get a lot of doctor googling going on now. With children and adult patients, really, people looking up medications and coming up with hypotheses about what medication they would like. In fairness to the point you're making, though, Mr. Moss, I think it's fair to say that he was more that way than most.
Yep.
Yeah.
If we could have paragraph 32, please, page 12. You next see AR on the 29th of December. You've mentioned that already, Doctor. You say you're conscious that you've not seen AR in clinic alone yet, and you asked to do so, and they agreed to that. And just looking at the totality of paragraph 32, it appears that on this occasion he seemed physically healthier again.
Yes. And
mental state apparently stable. Is that the overall impression?
Correct.
And you go on over the page in paragraph 34. The bottom of the paragraph, it's fine as it is on screen, thank you, Sarah. On each of the 3 occasions on which you met AR face to face, he presented in essence as an unremarkable, sullen, untalkative, gawky teenage boy.
Correct.
And I've touched on this already, but presumably you would have to agree that if you'd known the full forensic history of risk, you would have been more concerned about what might lie behind the seemingly unremarkable, sullen, untalkative, gawky teenage boy.
I think there's 2 elements to this which I think we need to be careful to distinguish. With the benefit of hindsight of the events.
Forgive me, I am going to interrupt you. Please don't use hindsight. But please think about what was knowable at the time, as I've explained it to you.
Yeah.
Had you known that which was knowable, either because it was known to other agencies and not communicated to CAMS, or more especially, it was known to CAMS because it was on the records, I'll ask my question again. You would presumably have been keen to look behind and what risks may lie behind the seemingly unremarkable, sullen, untalkative, gawky teenage boy.
The index of suspicion for potential risk of harm to others would have been increased, yes, although not to that level. I think that's the point I would like to make.
Not to a level where you may have foreseen the dreadful events of July.
Of course.
But if in that year he'd been carrying a knife and said that he'd been doing that because he wanted to stab somebody, it wouldn't just be higher, it would have been significantly higher.
I agree, yes.
But because it wasn't, presumably you didn't press him on issues about risk to others. You say you may have asked him about risk.
I definitely did ask him about risk of harm to others.
But did you then take his answers at face value if
Yes.
he denied risk to others?
Yes.
Because you didn't know the history.
I didn't know those elements of the history, no.
And looking at the system as a whole, rather than for the moment at your individual performance, that was a failure.
Looking at the system as a whole, in the system in the wider sense, it was a shortcoming, yeah.
Because as the treating as the treating psychiatrist, if you'd known about those matters, it would have been a significant part of your duty to ensure that they were explored with him?
Certainly beyond taking an answer of no
Yeah.
to a question of do you have any thoughts of harm to others at face value? Yes, I agree.
And that his risk to others was assessed and recorded rather than just focusing on the risks to AR.
Could you
Yeah.
clarify that point again, sorry?
So not just that you would have explored it, that it would have been your duty to explore it, but beyond that, his risk to others would need to be assessed and recorded, and I'm going to suggest shared as well, rather than just focusing on the risks to AR.
Well, it would have been a question of again not necessarily taking a negative answer at face value, but remaining having a higher index of suspicion that answer might not be
Yes.
correct.
But going on to that, when risk assessments were being done, the risk to others would have to be treated very seriously, recorded and shared.
Well, you can only go on what you've sort of got in front of you. I'm not so sure it wouldn't, would it? It wouldn't change the previous perception of risk of harm to others as nothing, but it wouldn't necessarily increase it. It would just I guess it would leave the point pending for clinicians working with him to need to look into further and establish a greater degree of assurance that either was or wasn't a significant risk, because there may not have been at that time.
Thank you. You formalised, I think, at the 29th of December appointment the cessation of fluoxetine. Is that effectively because he'd stopped taking it?
Yeah.
And decided on a retitration of the sertraline, is that right? Try it again.
That's what it says. Again, there's lots of there was lots of chopping and changing with the medications, and so my memory is a little not perfectly clear about these things. But that's what's written there. Yeah.
I'm asked to explore with you whether the continued attempts to restart SSRI medication was appropriate in a patient whose adherence appered to be so erratic. Can you help with that?
I mean, I think you've, from another angle, we were asked several times in the Rule 9 statements, what did you do to engage AR? Why did you not do more to engage AR? This I would see on the flip side of the point that you're conjecturing. I would see it as really our service bending over backwards to try and engage him in any way we could, given that he had a very specific shopping list, so to speak, of I want some medication that makes me feel better. I think it was incumbent on us to do what we could to try and engage him in that way.
Thank you. So that takes us in the chronology to the end of 2022. I think as we had a 10:30 start, it's not fair to go the whole morning without a break. Could we take a short break?
We certainly can. I'll sit again at 12 o'clock. Thank you. Yes, Mr. Austin.
Thanks, sir. Dr. Molyneux, we reached the start of 2023, and as you explained in your statement, in 2023, the next appointment was scheduled for the 6th of February. You can have on screen page 14 of your statement, paragraph 37. This is another occasion where AR refused to speak to you himself. But what you say at the end of paragraph 37 is that AR's father communicated that AR was largely being left to his own devices as regards the administration of the sertraline medication, evidently on account of AR's father's ostensible fear of riling AR through too close a level of scrutiny. Is that right?
Yes, that's correct, yeah.
And what was your assessment of that position in terms of how that might play out in terms of risks?
There wasn't a sense of serious violence from AR towards his father, from what was being told to me.
Was that not part of why AR's father was fearful of riling AR, because AR had attacked him on previous occasions?
The sense was, or as far as I could see it, the sense was of yes, aggression, but short of violence, not significant violence.
You tell us in paragraph 38 that arising from this, you had a sense of being uncomfortable because there was a relative lack of parental scrutiny around the taking of medication. Is that right?
Correct, yes.
And would you agree an inability, it would seem, on Alfonso's part to get AR to take his medication?
Yeah.
There was then a further appointment on the 27th of February. You tell us about that in paragraph 39 of your statement. I think that was an occasion where AR did attend in person. Is that right?
Yes, that was the last occasion on which he attended in person to see me.
And you described there that he was looking to be prescribed now with a totally different type of medication. Is that right?
Yes.
And again, what did you make of that?
It reflected, similar to what I recall having seen in the previous appointment, I think, this focus on his part of thinking of himself solely in terms of, as the only possible therapeutic options for him as being neurochemical.
And what about his knowledge of the different types of medication that he was actively seeking? Again, was that somewhat unusual?
Well, he'd clearly been Googling. Again, I wouldn't say it was particularly unusual in and of itself.
Now, after that, your next scheduled appointment was the 15th of May. But at the bottom of page 15 of your statement, you deal with an exchange you had the day before on the 14th of May involving Kate Morris, who by then had taken over as AR's case manager, yes?
Correct, yes.
And sir, for your note, it's AHCH 30185, the exchange of emails. But let me see if I can summarize it. It's right, isn't it, that effectively AR's father copied you into an email to school indicating that he wanted AR to have a different teacher on the basis that AR found a particular teacher to be boring.
That was what was apparent, yeah.
Yeah. I think Ms. Morris passed that on to you with a comment to the effect, seriously, no doubt referring to the seeming understanding that it was appropriate to ask for a change of teacher just because the pupil felt that the teacher was boring.
So, I don't know whether you've redacted one element of it, but it was I forwarded it to Kate with a kind of, I think a kind of, I think it was like 3 exclamation marks or something, really, just
yeah.
like can you believe it?
Rest assured, I haven't redacted anything.
No.
I'm trying to summarize it for speed.
Of course.
So 3 exclamation marks from you. She comes back with, seriously,
yeah.
This is more systemic than mental health, do you think?
Yeah.
And then you responded, don't know whether it's over-accommodation,
yeah.
safeguarding, gaslighting,
yeah.
or some combination of the above.
Yeah.
But the one thing that's clear is that it's systemic.
Yeah.
Now, just help us with that. when you said the one thing that it's clear it's systemic, what did you actually mean?
So systemic has a very particular meaning in the context of child and adolescent mental health practice. Systemic refers to, broadly speaking, family approaches. So family therapy would be considered the kind of the classic systemic therapy. So it's looking at the system, something wrong with the system, rather than something being a problem. The problem being located in the person, in the individual themselves.
So the family systems
Yes.
and the family dynamics as opposed to mental disorder.
Correct.
Is that a fair contrast? That's what the contrast you were seeking to draw.
Absolutely that.
And again, just focus on the questions, please. Over accommodation, by that you meant what exactly?
So over accommodation, so the parents basically being unable or unwilling to enforce and implement reasonable boundaries, and so just allowing their child to do what they want, in broad terms.
Yeah.
Yeah.
Safeguarding was the second option. So what did you, we all understand what safeguarding means in a general sense, but when you said you don't know whether it's over accommodation, safeguarding, gaslighting, what were you using safeguarding in that context to mean?
So my sense of safeguarding at that point, and indeed later, was solely in the sense of these, the systemic problems that are there, the parental either inability or unwillingness to implement reasonable boundaries, are not placing due life expectations on this lad, such that he will, he's going to have reduced opportunities in the world of education, training and work.
So reducing it to my layperson's terms, is it this sort of a concept that if you don't, in a way it's connected to the over-accommodation, if you don't set boundaries and insist, for example, that he tries to attend education regularly, he will end up having suffering and there will be a safeguarding concern because it will have a very detrimental impact on his life opportunities in the future.
Yes, exactly. He will have greatly diminished life opportunities. Yeah.
And the gaslighting in this context, again, it's a common term, but what did you mean using it as a psychiatrist here?
So I might need to refer to what I've actually written, because I use quite a subtle sort of explanation of what's going on. Really, what this spoke of to me, what it alluded to, was the interaction I'd observed between AR and Alphonse at the 27th of February appointment. This quite passive-aggressive bickering, and I'd actually written in the notes after that session that some of Alphonse's, I wrote a couple of things. AR's responses to Alphonse seemed to be sort of oppositional for oppositional's sake, just like if Dad said black, AR would say white. But from Alphonse himself, it seemed that there was one or two things that he said that seemed quite like they were in quite a subtle way trying to get under his skin a bit, and that's what I meant by the gaslighting.
Now, beyond the email and the exchange that you had with Miss Morris and what you recorded in the notes, you're clearly coming to this view of what you later describe as the overarching problem of this sense of not setting boundaries. Yeah. What did you actually do about that in terms of taking things forward?
So I communicated that to Kate Morris as case manager, so that she was aware, and so that remained our understanding. Well, I was kind of checking out what her opinions were as well, and I think she gives her agreement. But yes, so that in turn it could be shared with any sort of multidisciplinary professionals that are also involved.
Did you ever ask any questions about whether there was any boundary setting on AR's internet use?
I can't recall. I can't say that I definitively did not. I may have done.
I'll be corrected if I'm wrong, but I don't think there's any record of a specific time when you raised that within your notes of your discussions, either
No.
with Father or with AR.
No, again, I can't recall it being specifically discussed, although on the 25th of September home visit, which we'll come to in due course, no doubt, I had a good, comprehensive conversation with Alphonse in which I got a sense of the overall difficulties as they were being presented to us anyway.
And again, isn't that indicative? I'm going to deal with it at a systems level for now, but isn't that indicative of, again, the system not working properly? Because if you had been cited on concerns about school internet use, looking up London Bridge bomb, interest in Manchester Arena, and use of the internet to look up school shootings.
Yeah.
What for you was a lack of boundaries being set in, not insisting on AR attending school, not insisting on him taking his education, parents perhaps giving in to AR's wishes the whole time?
Yeah.
The potential for AR just to be doing what on earth he liked online in the family home would be an important other aspect that you would have wanted to explore, wouldn't it?
It would have been an important other aspect to be aware of, but again, I get and submit what you're alluding to, that if I'd have known about the previous aspects of internet use and things like that, that would have put a different complexion on.
Yeah.
Level of concern, yeah.
Because you didn't know about that, and again, I'm going to suggest in part because you hadn't informed yourself about that from the notes, that was never done. Again,
I would come back to that by saying it was an unknown. If I didn't know that there were concerns, I didn't know that there were concerns to be further explored.
Thank you. Be that as it may, the next appointment with AR was due the next day, the 15th of May, so the day after that exchange. And I think you can confirm that that was another occasion when he didn't attend, but AR's father emailed you to alert you to the fact that he wasn't going to be attending.
From memory, I don't have it in front of me now. From memory, I think you're correct. Yeah.
Paragraph 49, page 18. It's the minute to go before the scheduled face-to-face.
Yes, I recall that, yes, correct.
Yep.
Yeah.
And I think arising out of that, you, in fairness to you, followed that up. So you requested an update by email, given the non-attendance, and you received an assurance from AR's father, I'm looking at paragraph 50 now at the bottom of the page, that AR was consistently taking his sertraline at that time, and the only problematic aspect was with sleep, yes?
That's what it says, yeah.
And going over the page to 51, I think it was arising out of this, I think for the first time, that melatonin medication to help ease AR's sleep was first discussed and something that you recommended.
Something I suggested, yes.
Yep.
Yeah.
I'm asked to explore whether there's any contraindication to melatonin and sertraline being taken together in the case of a child. Are you aware of that?
None whatsoever.
There was then a multi-agency meeting on the 25th of May. You deal with that in your paragraph 53 at the bottom of that page, please, Sarah. And you say that the overall feeling expressed by school was positive in relation to AR's mental health, but it was apparent that he was only attending school very sporadically, yes?
Is that what it says? Yes, it looks that, it looks
bottom
that
of the
way.
page.
Yeah.
And you go on to say that this was, I think, a further indication that the overarching problem was essentially systemic and related to parental over-accommodation.
Yes.
Just over the page, I think.
Yes, from memory, That was my thinking at the time, correctly.
And this, I think, also, paragraph 55, you've dealt with it, but just so that we place it in time, was one of the two occasions, paragraph 55, when the PREVENT programme was mentioned.
According to my recollection, yes.
Thank you. I think thereafter, it's fair to say, isn't it, that there were attempts made to try to get AR to re-engage with direct contact?
Absolutely.
But by this stage, you hadn't seen him face to face since late February.
Correct.
Given what you in fact knew about the risk to others, which you described as understanding to be minimal, did you in fact think at this time that AR's lack of engagement may have given rise to an increased risk in relation to the risk to harm of others, the very fact that he was withdrawing?
Of others, to risk of harm to others?
Yeah.
Again, if my sense of things at the time were that he did not and had not posed a material risk of harm to others, it was not foregrounded in my sense of things at that time. In the absence, and I should add as well, you know, and this is a theme that runs through the whole story of AR's connection with services and with our service. Our sole conduit for information was Alphonse, and Alphonse was telling us Alphonse's concerns.
Well, Dr. Molyneux, that's not actually accurate, is it? What you've just said is that your sole conduit for information was Alphonse. Another conduit for information was the engagement between agencies and the information that's on the medical notes. That's another important conduit. If you'll forgive me, you appear consistently to go back to saying we could only take things from the family. But in 2019 and 2020 in particular, there have been a series of multi-agency meetings involving CAMs, sometimes involving FCAMs, and an exchange of information. That exchange of information may itself have been imperfect, but in all the ways that I've put to you, information in relation to that was on his mental health records that were available for you. So it's just not accurate, Dr. Molyneux, for you to assert that the only conduit for information was Alphonse.
A couple of points in response to that. I take your point about that there were multi-agency meetings going on live in the present. So I agree, you're correct to say that Alphonse wasn't the only conduit for information. The other conduit for information in terms of a present sense of what was going on was multi-agency meetings. And that one on the 25th of May was giving a sense of reassurance. Given that, why would I or anybody, if the sense is that there's an ongoing message of reassurance, why would it occur to me to go back and look through the notes just in case there's something that I'm not aware of that's different in the past?
But the overall pattern, if he's not attending school and he's not engaging with CAMs, at least in meetings with you, that might suggest that he's to some extent withdrawing from sources of support. And it circles back to the fact that had you known more about the risk information, the risk of others to information,
yeah.
That would have been something I suggest of a red flag.
I agree. If I'd have known more about the historic information regarding assessed risk of harm to others, that would have changed the complexion of my sense of him in the present time, at that time.
I think you were due to see AR again on the 3rd of July 2023 and then on the 18th of September 2023, and he refused to attend both of those appointments.
Correct.
Yeah. And as you described, can we just have it on screen, please, so that you've got it in front of you? It's paragraph 62, page 23. is this right, that you became concerned about continuing to prescribe sertraline to a 16-year-old who was not providing good evidence of his own consent to that medication?
Correct.
Thank you. And is that all the context? You've touched upon it, but was that all the context that led to the home visit that you carried out on the 25th of September?
Yes.
Let's turn to that then. So, home visit 25th of September, we'd have paragraph 63 at the bottom of that page. But on that occasion, I think, although you did a home visit, the family welcomed you into the living room, but it was apparent that AR, having been out previously, had gone into his bedroom, refusing to meet with you. And on this occasion, it's clear that he'd been in the living room just before, so he was definitely, my words, avoiding you.
Oh, yes.
If we jump forward in your statement, please, but it's talking about this occasion. It's page 31, paragraph 82 at the top of the page. Page 31, paragraph 82. You refer there to Alphonse being, and then your words are these, cheerfully unable or unwilling even to attempt to place upon AR the reasonable expectation that he at least speak to me.
Yes.
And he spoke, that is, Alphonse spoke, of AR being seemingly happy just doing what he wants to do.
Yes.
And that cross-reference is back to paragraph, the paragraph, I think, dealing with this meeting. Can you just expand on that and the reference there to seemingly happy just doing what he wants to do, that's AR, and to Alphonse being cheerfully unable or unwilling to attempt to place upon AR the reasonable expectation of speaking to you? What did you mean by those things?
Well, I guess what I've said. It was. I think I used the word. I think it's just a little bit above this. I used the word exasperation. The picture as it was presented to me was one of this lad chopping and changing his engagement, messing about with medication, doing what he wanted with it, and Dad, not seemingly concerned about the lack of boundaries he was able to enforce, really. And this was a lad who, moreover, was not confined to his room, but had been just merrily in the living room doing what he wanted, having his snacks and things, and then doing what he wanted and scarpering to his room. So my sense was, why are we as a service continuing to bang our head against the wall with this lad who has been deemed time and time again not to have a mental disorder, and for whom this is primarily a social care issue of parents not being able to implement boundaries or willing to implement boundaries?
Is there a risk that you, in forming that view, were underestimating the level of difficulty for AR's parents, and quite how difficult AR's behaviour had made things for them?
I recall, Mr. Moss, that this was a specific question that came from the parents, wasn't it? From Alphonse and Letitia, I think. And honestly, when you look back with the benefit of hindsight and the chronology from what we now know of what was going on, from the purchases that were being made, from the Royal Mail deliveries at the house and things like that, I find it a little bit, I don't know what the word is. I wonder how the parents can say that there was what was the word you used? Sorry.
I asked if there was a risk that you were underestimating the level of difficulty for AR's parents, how difficult his behaviour had made things for them.
I wonder how the parents can say that when we now know that what they were doing at the time was taking orders for machetes and whatnot being delivered to the house, but not telling anyone about that.
And is there any truth in their perception that your input was very high level and superficial, and that you showed no inclination, pleasant though you were, you showed no inclination to get to the bottom of the problem?
Again, I dispute that in its entirety. I am, is the very fact that you've got a consultant psychiatrist doing a home visit here not demonstrative in itself of really trying to do what I can to get to the bottom of the problem. But of course, like any other clinician in this situation, you can only go on the evidence that's presented to you. And if, as it later seems to have turned out, with the benefit again of hindsight, if it was the case that the most salient evidence indicative of AR's presentation was being evidently deliberately withheld from us, can that be a criticism that's levelled at clinicians?
You'll understand that I'm giving you an opportunity to comment on that, which is part of the process of achieving fairness for you, so you can comment upon it.
Thank you.
So as you know, but others may not, but it's just been indicated by the doctor that it was possible for us over the weekend to put extracts from AR's parents' statements, but only extracts to this witness, so that he's able to have that opportunity to comment. It's not been possible yet to disclose the statements, but that is imminent, so all the other call participants will get them very soon. Thank you. On the same occasion, I think AR's father informed you that AR had stopped taking the sertraline about 2 months ago, is that right?
I recall that was the case, yes.
Yeah. And as a result, I think you decided to formalise the cessation of sertraline, again on the same basis that if you stop taking it anyway, it's not appropriate that it continues to be prescribed.
Correct.
Thank you. You say in paragraph 78, still in relation to this home visit, that it might conceivably, I'm so sorry, it's paragraph 78, page 29. So in relation to this visit, it might be wondered as to whether indeed I was satisfied that the information provided to me by AR's father was reliable, particularly given that I'd been unable in the course of the visit to examine AR in person. The answer to such question would of course be yes. At the time, I had no reason to doubt AR's father's reliability or honesty. Subsequent to the events, the horrific events, it's quite a different matter. I doubted his effectiveness as a parent, but that's quite a different matter to doubting someone's reliability or honesty. And were you there reverting to the same aspects that perhaps through this inquiry or through the criminal process, you've subsequently become aware of the delivery of weapons,
yes,
which you would understand one or both of the parents were aware of, but never mentioned to you?
Never mentioned to anyone, I gather. Yeah.
Thank you. Following that appointment, I think you emailed Miss Morris, so for your note, AHCH 30145. Thank you. But I think the essence of it was you hadn't been able to see AR for over 6 months. He hadn't been taking his medication. He was remaining in his bedroom. He hadn't attended college. He'd only attended a couple of times in the term. hadn't left the house for the last few months, spends all his time watching videos online, including late into the night, hadn't had a bath or a shower in the last month. Early help were apparently closing the case. It seemed as though a social care worker was involved, and you concluded with a phrase that you use repeatedly in your statement, that you were struggling to see if there's any further role for psychiatry or CAMHS as a whole. Is that right?
Correct.
And is that because in the circumstances where he's not complying with medication and wasn't seeing you, and parents, for reasons that we'll explore obviously with them, were not being successful in encouraging AR to see you, that you couldn't see what it was that the CAMHS service, and you specifically as a psychiatrist, were really, my phrase, bringing to the table?
Essentially, yes. So you've got a young person who has been in the service for a good while, has never presented with a diagnosable mental disorder. Is evident. We're very clear by now on our formulation as being a systemic one of parental over-accommodation. This is the issue. He's, and so what? He's indicating by his repeated actions that he does not want to engage with CAMHS. So how is it productive or helpful for CAMHS to remain involved when the lead agency at this time ought to be social care?
Thank you. And again, although it's a theme that I've put to you a number of times, I do need to come back to it here again. If you had known what was capable of being known at the time about previous risk history, risk to others, wouldn't all of these features, so increasingly isolating himself away, he's disengaged, he's not engaging with mental health professionals, he's spending an increasing amount of time on computers, wouldn't they all have flagged up actually an increased risk of concern about the risk to others?
I think that's a fair comment. It would have put a different complexion on things, and even if not by themselves necessarily hugely significantly so, it could only have increased the sense of a risk of harm to others that would warrant further exploration.
And just think about that. And again, I seek your candid assistance. Where would that have gone? Would one possibility have been that you would have kept him open to CAMHS because of the risk to others? Is that one possibility?
I guess what it would have done is increased our index of suspicion, and yeah, it's difficult, isn't it, to kind of separate out what was known at the time with what's known in hindsight. But again, we're thrown back on the fact that he is not engaging with CAMHS. I guess social care would still have been the lead agency, but it would have warranted more flagging of the past risk of harm to others.
But forgive me, the answer to my question, that one possibility would have been, would it not, keeping him open to CAMHS for longer, principally because of the risk to others?
That would have been one possibility.
And I think I'll come back to the fact that you described social care as still have been the lead agency. But would this be right, that even if he was going to be discharged from CAMHS, in terms of the risk of harm to others, you would have wanted, before his case was closed to CAMHS, to make sure that our other agencies were aware of that? So a multi-agency meeting where CAMHS explained why they were closing the case to him, but flagging up, he's disengaging, we can't do anything physically more.
absolutely.
But we do have these concerns about risk, and actually the fact that he's spending more time on his computer, the fact that he's not engaging with us, the fact we can't even see him, is all quite concerning.
Yeah, so past concern around risk of harm to others, period of ostensible lower risk of an apparent lower risk of harm to others, and now a further lack of engagement. Yeah.
If we could look, please, together, Doctor, at paragraph 77 of your statement. It's page 29. I want to explore another possibility of course of action with you. So you say in your paragraph 77, if the adjudged risk had been high, based on the information available to us at the time, in the context of a suspected mental health disorder, we could and of course would have considered arranging an assessment under the Mental Health Act 1983 as amended. Is that right?
Yes.
I think you go on to say that that might have been an avenue that might have been explored at the earlier stage if AR's lack of eating and malnourishment and being underweight had become to the stage where there was a significant risk to his own safety.
It might have reached that point, yeah.
Now, that didn't transpire in terms of the risk to himself from undereating. But I want to ask you about the risk to others and the Mental Health Act possibilities there. Would that, in fact, if you'd known all of this about AR's history, and he's now disengaging, refusing to see you, refusing to see others, would an assessment under the Mental Health Act have been something that could have been considered?
Could you just ask that question again, sir?
Yeah. If you'd known about the indications of risk, and then on top, AR is refusing to see you, he's refusing to see others, he's not really attending school, would an assessment under the Mental Health Act have been something that could have been considered?
I mean, so you would request a Mental Health Act assessment if you're concerned that there's significant risk of harm to self or others in the context of a mental disorder. It's difficult to say, isn't it? If I'd have been cognizant of earlier ostensible risks of harm to others, I think we have to be careful that we don't let hindsight kind of cloud this. I mean, what we're left with is a situation where, as things stand, and as things are apparent to us there, that threshold for considering a Mental Health Act assessment, I mean, a Mental Health Act assessment just wouldn't be considered in those circumstances. If Mental Health Act, if young people presented in that way were an indication for a Mental Health Act assessment, given what we knew at the time, Mental Health Act assessments would just be happening all over the place and everywhere.
Well, you say that, but could we have a look at the views of the inquiry's independent expert, Dr. Irani? So this is DRI 501, please. And you'll be familiar, I'm sure, with this report.
Mm-hmm.
And if we could go to page 21. If we could pick up at the top of the page, please, paragraph 3.2.2.1, it's the top paragraph. AR was out with the parental control. He'd been presenting a risk in the family home. He was withdrawn and spending considerable periods of time on his computer. He wasn't looking after himself. He hadn't showered for more than a month. Would you agree with all of that? Again, I
I wouldn't have regarded what's reported there as being a risk presentation to others in the family home as significant from what was being presented to us.
No, but from what was knowable from the records. So you've got those 2 incidents in November, remember, of violence in the home, and 2 further incidences of violence.
November when, sorry?
November 21. 2 incidents in November 21. There's the earlier occasion of an assault on father in the course of throwing juice, and then May 22, there's further incidents of in the home. So I think Dr. Irani was here looking at what was on the records and what was capable of being known. Presenting a risk in the family home seems a perfectly reasonable conclusion, doesn't it?
But again, so you have to go on what the current risk is as it's being presented to you, and the current risk as it was being presented to us by parents wouldn't have been sufficient to trigger a mental health fact assessment.
Dr. Mulley, this was a father who was afraid to insist to his son on taking medication for fear of how he might react against a background of reported previous assaults by son on father. It was never
put across that there was a fear of serious violence. It was described just as aggression.
Yeah. But again, that reflects in part material that was knowable on the records that you weren't aware of. The previous occasions where it seems that AR had assaulted his father, and other occasions where he had violently thrown things around the family home.
Again, though, we had never characterised him as meeting criteria for a mental disorder, so I wouldn't say that going to the mental health act, proceeding to the mental health act.
Leave that to one side for the moment, but the plain words from Dr. Irani, he had been presenting a risk in the family home, and that's just accurate, isn't it?
But the risk, as it was presented to us at the time, did not appear to be, in terms of aggression towards parents, did not appear to be one of significant violence.
You don't fully agree with that. Do you agree with all of the rest of it? Out with parental control, withdrawn and spending considerable periods of time on his computer and not looking after himself?
I do, although I think it's a salient point that certainly warrants mention. That, I mean, the way I would look at it in terms of my findings of that assessment from that home visit of the 25th of September 2023, the one element that was a lingering cause of concern did appear to be the not having bathed or showered for a month. I was then, within 48 hours, given explicit reassurance by Alphonse in an email that said, "It's good. Hi, Dr. Molyneux. It's good news here. Alphonse AR has had a shower." So an explicit communication of good news, an explicit communication of reassurance.
Again, we must move on for the sake of time, but an email, which is right that you alert to, indicating that he'd had a shower on a single occasion, doesn't mean that he'd started looking after himself properly.
Well, I mean, with respect, when a parent who you have no reason at this point not to basically trust. I mean, as I've said earlier on, I doubted his effectiveness as a parent, but I didn't doubt his reliability or honesty. When a parent is putting to you by email an explicit communication of reassurance, it's good news here, I think a clinician's warranted in accepting that, in the absence of any indication not to.
Had you made any queries to how frequently he was actually showering, given the report that he hadn't done so for a month or so?
Well, again, if a parent is saying it's good news here,
right.
Good news sounds like good news.
I'm going to move on. Right back in September 2023, when reviewing his attendance and parents' inability to make him engage, these should have been escalated through safeguarding. Do you agree with that?
So around the same time, no, as I've said, I don't, on the basis of the knowledge that was in front of me at the time, I absolutely do not believe that a mental health fact assessment was indicated.
Forgive me. you must, Dr. Molyneux, please forgive me, but you must listen to the question and what you're being directed to. I'll come to a Mental Health Act assessment, but what Dr. Irani is saying here is right back in September 23, when reviewing his attendance and parents' inability to make him engage, these should have been escalated through safeguarding. So raising a further safeguarding concern to the local authority.
So the email that I communicated to Kate Morris, the case manager, and by extension to Sam Coppard, explicitly said that I did regard this situation as problematic. I did regard the situation to present with risk. The greatest seeming risk being risk of, due to the parental over-accommodation, risk of non-engagement with life opportunities, work, training, and vocational aspects. I asked Kate Morris and by extension Sam Coppard for their opinion, and they completely agreed with the conclusion that this is not for CAMS, this is for social care. So I don't see what a safeguarding discussion would have achieved, given that we're all in agreement, 3 experienced clinicians are all in agreement that this is primarily for social care. A safeguarding discussion would at that time, knowing what we knew, just have agreed with that conclusion.
So if it was to be matters that social care would take on rather than CAMS, does that not reinforce the need for safeguarding concerns to be raised, to say we're not in the best position to deal with this, but you, social care, should. So we want to raise this as a safeguarding concern, but we're going to move to close him to us.
So yeah, I mean, a discussion with social care would have you know, obviously by nature of the situation that's being discussed with them, would have flagged safeguarding concerns. Yeah.
Yeah. Around the same time, when CAMS were unable to meet directly with him, and then please note the words. What she's saying is consideration should have been given to carrying out a Mental Health Act assessment. Mm-hmm. All right. Now, that's not saying that a Mental Health Act assessment at this stage should have been done, but it's at least indicating consideration should have been given to that. Do you agree with Dr. Irani on that or not?
I agree in a probably quite literal technical sense in that I did give the matter of a Mental Health Act assessment due consideration, in the sense of not considering it because it wasn't indicated. I gave the matter its due consideration.
And do you think that, well, you say you gave it due consideration, but by definition, your consideration that you gave it at the time could not have included all of that information about risk to others?
Well, no, but historic risk to others. But I think, or historic adjudged risk to others. But I do think it's really difficult to separate out the benefit of hindsight of what happened on the 29th of July 2024. You know, we mustn't lose sight of the fact that early on, and I think this is a really important point, early on, the clinicians who were involved early on, if they're getting three feedback reports from Prevent saying this doesn't need further escalation, that's 3 items of reassurance.
But you, again, we come back full circle, but the extent to which Prevent not taking them on for that particular programme is reassurance of a lack of intention to cause violence to others, would require scrutiny of at least what your own records showed about the Prevent referrals.
Well, as I said there, I was putting myself in the position of the clinicians who were involved at the time. As I've said already, my knowledge of the involvement of Prevent was that there'd been one.
Yeah.
And it was to do with, you know, the.
Dr. Molyneux, I understand that.
And it had been, and no further action required and all the rest of it.
For the purposes of all these questions, would you assume that you had a full picture of the risk information? So at least everything that was on the CAMS records from 2019 onwards about previous risk information was known to you and answer the questions on that basis. So I think what you're saying is consideration was given to a Mental Health Act assessment on the information you had, but you didn't think that it was appropriate. Would you accept that that should have been looked at much more closely if you had that additional risk information?
I think Dr. Irani says in her report, doesn't she, that she concedes the point that a Mental Health Act assessment wouldn't have identified a mental health problem, but I think she says it would have provided an opportunity to.
Dr. Molyneux, just remember, my question was, would you accept that that should have been looked at much more closely if you had that additional risk information? Do you accept that?
I accept that the index of consideration could only have been higher.
Thank you. And then turning on to Dr. Irani's view, if we go to page 25, please, and look at paragraph 3.4.4.1. And it may be that this is what you're alluding to. Whilst it's not common practice to consider a Mental Health Act assessment every time a young person disengages from services, given AR's historic risks and his presentation, or the lack of physical evidence of his presentation in the early half of 2024 should have prompted a Mental Health Act assessment. Do you agree with that?
I mean, he never presented with suggestion of a mental disorder. I'm not so sure I do agree with it.
Can I ask you two aspects of the mental disorder? You made clear in your statement that the symptoms of anxiety that AR had, you don't think amounted to a mental disorder. They weren't so severe as to amount to a recognised mental health disorder classified under ICD or
Correct.
DSM. Yes?
Correct.
What about conduct disorder?
So conduct disorder is a kind of a diagnosis of exclusion, really. It's not a mental disorder. It's really just a cluster of features of antisocial behaviour. It's not considered a mental illness. It's not considered a mental disorder.
So you don't think that would have qualified as a mental disorder under the Mental Health Act?
My understanding is that it might be technically possible to detain someone. I mean, but that would be done in a forensic setting, not by a community CAM service. And you'd need to know that somebody ticked the boxes for that diagnosis.
Yeah. And at the very least, with all of the information about risk from his previous behaviour, that's a diagnosis that would have warranted consideration. Yes?
Consideration, possibly.
And I should ask these questions carefully, knowing that there are post-event changes to the law in the way that autism is dealt with so far as the Mental Health Act is concerned. But AR's autism itself, could that not at the time potentially have qualified as a mental disorder for Mental Health Act purposes?
So autism is considered as it's convention, really. It's just how things are kind of construed. Autism is considered as a neurodevelopmental disorder. Autism really just refers to the fact that somebody is presenting with, if you look at the diagnostic criteria, it refers to the fact that somebody is presenting with significant and pervasive social communication difficulties. In other words, significant and pervasive social hypersensitivity and significant and pervasive rigidities of thinking, behaviours and interests. Significant and pervasive meaning, by definition, these items are long-standing. These features are long-standing. The move over recent years, and I think rightly so, has been to discourage detention and admission, and indeed voluntary admission of young people to inpatient units who have an autism diagnosis, because such people tend not to do well in inpatient units.
I understand that, and again, there are changes to the law subsequent, or proposed changes to the law, to remove autism, as I understand it, from Mental Health Act. But at the time, were you not aware that autism could qualify as a mental disorder for the purposes of the Mental Health Act?
I mean, again, it's a technical point. It's not done in practice. You don't see people detained under the Mental Health Act for autism in practice, or you haven't.
So, if that be right, and we'll obviously explore with Dr. Irani her view that Mental Health Act assessment should have been done, but if you are right that there wasn't a power, does that show, in fact, that there's a gap in the legislation? Because there's nothing that can be done in this situation in terms of detention to carry out an assessment, even for a short period of time, even though this young person is locking himself away and refusing to be seen by professionals against a risk of harm to others. Is that a gap in the legislation?
I don't know. I guess it could be argued as such. I'd be very careful. I mean, I'd be very careful about demanding the need for more laws, really. I can see there might be an argument for it. I mean, again, from my point of view, looking at this whole case in retrospect, what strikes me more than anything else is the unusualness of the parental presentation, really. The evidently, and again, this by its very nature, this is something that's only possible to see with the benefit of hindsight. The extent to which parents were evidently.
Dr. Molyneux, I am going to ask you to focus on Mr. Moss's questions rather than engaging in ruminations about your overall.
I understand,
so
sir.
Can you
I beg your pardon.
focus on the issue in hand,
Of course.
please?
Apologies, sir. In the short
No, can you wait for the next question?
Apologies.
Thank you.
Then moves to the stage where there's a decision to discharge AR from psychiatry all together. I think that was at the 16th of April. And at that stage, would you agree that rather than having reduced, in a sense, AR's needs and the concerns about him had escalated by then because of that sense in which he'd withdrawn?
By the 16th of April 2024?
Yeah.
No, I disagree with that. I'd been given numerous, as is set out in my Rule 9 report, I've been given numerous reassurances by email by Alphonse of explicit and implicit reassurances that Axel was stable and well. So I wouldn't accept it on the basis of the knowledge that we had in front of us that there was evidence of a deterioration.
On the community dietetics side, by the 20th of February, it had been reported that he'd not left the house for 4 to 5 months and had an erratic eating pattern again.
4 to 5 months.
4 to 5 months.
Yeah. I never received that letter, by the way. I know this was something that was addressed in the Rule 9 report. But again, if it was described that he hadn't left the house in February 2024 for 4 to 5 months, that would imply, I think this is a point I picked up on in my report, that would imply that he had left the house in September, October time, which was shortly after, you know, my home visit where Alphonse was saying that he hadn't left the house. So overall, there was clearly periods of time where he was leaving the house.
Coming towards the end of my questioning, just a few further areas, please. I should ask you for your assistance and your comments upon Dr. Irani's report in different aspects. So DRI 501, please, this time at page 21. I can take it fairly briefly. Paragraph 3.3.1.2, please. So penultimate paragraph on this page. So AR had a history of repetitive and persistent pattern of behaviour in which the basic rights of others or major pre-age appropriate societal norms, rules or laws are violated, such as aggression towards people, destruction of property, deceitfulness and serious violations of rules, which predates his first contact with CAMS. And in line with ICD 11th edition, he would meet the criteria for a diagnosis of conduct dissocial disorder. I think you accepted earlier that would have justified consideration. Do you agree with Dr. Irani that he actually met the criteria for that diagnosis?
Again, lots of those elements weren't available to me.
Assume that they were.
Assuming they were. If he's deemed to meet those criteria, then I suppose by definition he does.
No. And knowing what you do now, have you got any reason to doubt that he met those criteria?
Knowing what I know now, I mean, he absolutely would meet criteria for that. Yeah.
Thank you. And page 33, please. Same report. Page 33. Paragraph 4.4.7. In AR's specific case, it's Dr. Irani's view that a diagnosis of autism in someone who does not have a learning disability and is of normal intellect increases the risk, particularly if the risk is associated with their area of special interest and is accompanied with a lack of empathy. Do you agree with her on that?
I mean, I guess in parts, I wouldn't necessarily say that a diagnosis of autism and is of normal intellect necessarily increases the risk. I think if somebody who meets criteria for diagnosis of autism or doesn't has an actual genuine lack of empathy, as opposed to just a judge lack of empathy. So if somebody, in other words, if somebody is autistic or not and has a genuine lack of empathy, that increases the risk of harm.
In AR's case, it did increase the risk, didn't it? Because he did have a lack of empathy.
That would appear to be the case.
Yeah. And he did have concerning special interests. See his known concerning internet use and fascination with violence.
That wasn't known to me, but...
No, but it was knowable to you. So whichever way you take it, in AR's case, it was increased risk, both because he had a lack of empathy and because he had concerning special interests.
I guess concerning special interests, risky special interests, by definition increases the risk.
Thank you. I'm going to draw matters to a close so that I leave time for any questions for others. Can I indicate that there are sections, Dr. Molyneux, in your report which are helpfully detailed on improvements, so for your note 122 and following, and recommendations 126.
Thank you.
Your statement, Dr. Molyneux, stands, so I don't need to go through the detail of those, but thank you for the detail of them.
No problem.
But I want to just look at your reflection on events towards the end of your statement at page 45, please.
Yes.
So statement at AHCH 30253, page 45. You said this: on reflection, as the above narrative chronology strongly bears out, I am 100% confident that not only did I and my organisation do everything we possibly could and should have done to correctly and appropriately assess, treat where relevant, support and engage with AR and his parents at every turn during our period of working with them, but moreover, we quite clearly went way above and beyond the bounds of what ordinarily be expected of a CAMS service in order to do so. Do you want to amend that assertion in any way?
I still agree with it in parts, but I do take your point. I think the challenges that face our service, which was fortunate enough to get an outstanding result at an impromptu CQC inspection in March. I think the challenges that face our service and every service, health, social care, police, etc. The public sector, public services are busier now than they've ever been. At the same time as that busyness has increased, fragmentation of services due to privatisation and deregulation, all the rest of it, has militated against joint working. Therefore, in my opinion, no matter how hard anyone and everyone works within these services, there are system gaps which can only be remedied, I think, by having a unified system, and possibly as well, I think it would be a helpful move forward to kind of make use of AI to mitigate against the easy propensity for information to be lost in systems.
Briefly, what do you mean by a unified system?
I would like to see public sector agencies be able to access information from each other.
So going back right to the question I asked you at the outset about, do you have access to other agencies' information on some sort of
not easily, no.
You don't have that?
Not easily, no.
All right.
Not quickly or easily, no.
Dr. Molyneux, no one would doubt the difficulty of the task, even if resources were endless, which they're not. And I don't want my brief further questions on this to overlook the perfectly valid point that you've made in that regard. But is not an important reflection that was missing from your statement the fact that the risk that AR posed to others became almost completely lost in how CAMS dealt with him?
I think there's an element of truth in that. I think during the middle part of his presentation, at the middle part of his trajectory of care, there was an improvement, and also, you know, whether genuinely or ostensibly, he was presenting with evidence when asked, etc. He was of low risk of harm to others. I think early on, as I alluded to earlier on, I think COVID was an important watershed that muddied the water and made continuity of care difficult. I think another factor right across the public sector increasingly these days as well is the high turnover of staff. And when there's high turnover of staff, that increases gaps in systems. And my sense is that those gaps that were unavoidable seem in retrospect to have provided an opportunity for parents to manage the flow of information in a way that presented a different picture of reality to professionals.
But when you drafted this statement at the very tail end of July of this year, you knew by then about a lot of the risk information that I've taken you through. You said, I was aware of that later. Yes?
Some of it I've become cognizant of more of that information as time's gone on.
Presumably you'd read through AR's notes, for example.
It was a very quick turnaround time for producing the reports, wasn't it?
But presumably you read the notes before you drafted this statement. Pretty basic.
Yes.
Yeah? And having read the notes and seen the risk information that was available in the notes, you still said, I'm 100% confident that not only did I and my organisation do everything we possibly could, if it was assessed to you, it's concerning in itself that you did not recognise that shortcoming in producing your statement, what would you say?
I guess that statement there is a reflection of my honest view that I see my colleagues work so hard. And if you could see, email timestamps flying around between staff, like where people are up till all hours of the morning and really, really exhausting themselves doing everything we can for our young people, then the level of need in our society, as things have collapsed over recent years, the level of need has absolutely skyrocketed. And so my 100% confidence statement, I'd like, if possible, to convey that as a reflection of how proud I am and how positive I am in my view of my colleagues and the job they do. Having said that, I take your point and I concede the point. There are or were gaps in the system, and our organisation have taken steps to amend and improve those, as we are always looking to do all the time.
I follow. Thank you. I'm just going to turn to my left. Mr. Weatherby.
Yes, Mr. Weatherby.
Thank you, Dr. Molyneux. Two very short points from me arising from what you've said. At the top of your evidence, you referred to the impossibility of being able to read through all of the records on handover.
Yes.
Mr. Moss took you to the standard operating procedures about what was required. Given what you've just said a few moments ago, is the mismatch between those two points, is it resources? Is it caseload? Is it having too many cases?
Yes, I mean, and that's not a criticism of our organisation at all. I think we at Alder Hey do a fantastic job and do as good a job as could be done.
You do the best within the resources you've got, but the resources.
I think we really do, and the CQC agrees.
Yeah. So if you were properly resourced, then you would have expected yourself to have read through the records that Mr. Moss has taken you through.
I mean, absolutely, yeah. Any clinician can only make risk judgments on the information that's available to him or her at the time, and so there's a kind of internal triage process that goes on.
Yes.
As you're attending to your caseload.
They can only make the risk judgments on the basis of the records that they've read. Yeah. The second point, and quickly, given what you've said about the impossibility of going through all the records on handovers, do you think there should be a field on the electronic patient record showing or listing key historical incidents or key historical evidence of risk to self and others? Is that one mitigation of the problem that you've highlighted? Those steps have already been taken by Alder Hey, so salient information is now, due to amendments and modifications and developments of the ERP, EPR, I should say. So in a similar that salient information is now much more visible, right? So all in one place. In a similar situation, on the EPR, you would look at it and you would see a box or a field which showed the matters that Mr. Moss has gone through. Thank you very much.
Yes, Mr. Byrne.
I ask questions on behalf of the bereaved families, and I'd just like to spend a few moments asking you about conversations that you've had with other staff members over your time in the case.
Of course.
First of all, Samantha Steed.
Yes.
Who I think was the case manager between August 22, I think, or sorry, and could be. I think she came to around August 22. Yeah. Yeah, finished on the 5th of September 22. So, yeah. So she was there at the earlier stage, and then we had Catherine Morris.
She was, Sam Steed was case manager number 3. Kate Morris is case manager number 4.
Yeah, I think April 21, is when she started.
Yeah.
And then Morris 5th of September to July 24.
5th of September 22.
22,
yeah, correct.
22,
yes.
yeah.
Yes, that's about right, yeah.
And your broad point, as I understand your evidence, is that for all the reasons you've discussed, you're effectively in the dark about the really crucial red flags at an early stage.
At about in the dark about historic.
Yeah, the forensic. I won't go through it now.
Yeah, of course. Yeah.
Through it. Yeah. And just assuming, for the purposes of my questions, that Steed or Morris knew more than you.
Right.
Okay. Let's not. We haven't got time to go into what they knew.
I'm not saying they necessarily did or didn't, but yeah.
All right. Okay. You must have had detailed conversations with them through your lengthy period of time on the case with both of those case managers.
Yes.
Yeah. The role of a case manager is, one assumes, to be thoroughly invested, insofar as time and resources allow, with the patient.
Yes.
So they'll know the history.
Yes. If I could just go back to your last point, Sam Steed's role as case or time as case manager came to an end just as mine as my time as consultant was beginning.
Yeah, exactly. And I think, and there are documents, we don't have time to go through them, and emails between you, discussions about safeguarding incidents, for instance. Do you remember that? There
was one email from Sam Steed it's early on in my Rule 9 statements, isn't it? So it's an email that was sent as a reply to an email from one of the secretaries to say that they'd cancelled an appointment, and Sam Steed did a joint email reply to myself, Vicky Killen, our clinical lead.
That's right. Yeah. And I think that the reference for that, sir, is AHCH 00290 and 000164, I think. Okay. Right. And we know from Catherine Morris's witness statement, so again for your note, particularly paragraphs 119, 168 and 180, that's 000278, that certainly at those periods of time, and for those references, it's 5th of June 23, that's 119, sir.
Okay.
22nd, I think, of February 24, 168, and the 23rd of July 24, she gives evidence specifically about the referral to CAMS being due to low mood, radicalisation, bringing knives to school, attacks on peers, and police involvement. Okay. Now, during your, how many times did you speak to Catherine Morris over the period of your involvement?
Quite a few.
Yeah, it's a regular thing.
I wouldn't say regular, but on a number of occasions.
Yeah.
Yeah.
And if she had known about the really significant events in the past that would have flagged up risk to others, she must surely have mentioned it to you.
I mean, again, I can't speak for Kate Morris and what Kate Morris knew or didn't know when. I know she's a great case manager. I think, and I've alluded to this point already a couple of times in my submission today. I think we need to be really, really careful about that. We don't let hindsight cloud.
It's a straightforward question, Dr. Molyneux.
I beg your pardon.
It comes down to, surely Ms. Morris mentioned those matters to you. So what is your memory of that? Did Catherine Morris mention low mood, radicalisation, bringing knives, attacks on peers, and police involvement?
I don't have a recollection of Kate Morris mentioning the radicalisation, knives, etc. bit. I have a recollection of Kate Morris referencing the prevent referral that had then been rejected.
Thank you.
That's my recollection.
I don't think anybody is expecting you to remember everything that was said.
No.
All right. But would you agree with this then? If Morris knew, and I'm saying if, okay, if Morris knew, well, I don't say it because she did know because she's told us. So given that Morris knew,
Right.
do you think it's more likely than not that it would have come up in a conversation?
I'm not so sure I can answer that question. I feel like I'm being expected to, or being asked to comment on what Kate Morris knew or didn't know when, and I don't think it's an easy question to answer. I'm sorry.
I think Mr. Birmingham exhausted this.
Okay.
He said
I won't go. I'm grateful, sir. Just one more point. Did you know about the bus incident?
No.
Nothing. Okay.
Thank you very much.
Thank you.
Dr. Molyneux, thank you for your evidence.
Thank you, sir.
You're now free to go.
Thank you.
Thank you.
Thanks.
It's 2:05.
Certainly.
Thank you, sir.
We'll sit again at 2:05.